In the name of God, the merciful, the compassionate. Assalamu alaikum wa rahmatullah. Good evening for attendees who joined us from the Middle East, and good afternoon for attendees who joined us from Europe. My name is Dr. Tariq Azzeddin, Institutional Research Official, Consultant and Medical Program Director, and I'm honored to be your host today. Welcome, dear colleagues and attendees, to the workshop webinar of today, titled The IRB Coordinator Roles and Responsibilities in Oversight Monitoring, and this is a workshop part 3. This workshop is under the care of Training and Academic Affairs at Dammam Medical Complex under Dr. Malik Al-Mutairi, so we thank him for his support. Also, I wish to thank the event team for preparing this event on short notice and for their professionalism. The workshop today is organized in an updated interactive way between the trainer or speaker, Mr. Naeem Nuruddin, and 15 actual and future coordinators, so that the information be explored in a more attractive form of scenarios and problem-solving way. So let's start first with introducing our speaker today, Mr. Naeem Nuruddin, CEO and Managing Director, Sierra Limited UK. Mr. Naeem is a graduate in pharmacology with toxicology from King's College, University London, where he started his career as a clinical pharmacokineticist. During his 20-year career, Mr. Naeem has held various positions of increasing seniority and is actually the CEO of Sierra Limited UK, which he founded in 2007. His company, highly specialized and focused organization offering training, development, and consultancy in all aspects of International Council for Harmonization and Good Clinical Practice and related guidelines, as well as for personal effectiveness and behavioral skills. Mr. Naeem brings with him over 20 years of experience in clinical development, training, consultancy, and education, spanning Europe, United States, Middle East, and Asia. Mr. Naeem is also a lecturer at Cranfield University, UK, and a certified facilitator and behavioral skills trainer. Mr. Naeem has worked extensively in the Middle East and Asia, developing and building clinical research capabilities with the region. While in Saudi Arabia, Mr. Naeem was intimately involved and chosen to establish the structure of the Ministry of Health Ethics Committees, and was heavily involved in developing the standard operating procedures and deploying the training for the Ethics Committee members nationally. Please welcome Mr. Naeem Nuruddin.
Thank you very much, Dr. Tariq, and good afternoon, everybody, and welcome to the last webinar. And it's great to see a lot of faces, well, a lot of names I can see over there. So we've got lots to cover today. So what I'll do is I shall share my screen and then we'll get straight into it. Okay, can everybody see my screen?
Yes.
Yes, okay. Okay, so we'll get straight into this. So what we'll do is I'll get a very quick refresher of the objectives we had. Really wanted to make sure you understand what the roles and responsibilities are of the IRB coordinator when you're doing this, conducting this monitoring or this oversight of health-related research and studies. And we started off with our first webinar looking at our roles and responsibilities. And then during our second webinar, we started looking at some of the activities that we will do. So when we as IRB coordinators are doing this oversight, what are we actually looking at? What are we going to do to ensure that the right safety well-being of clinical trial subjects is protected and that the data we get from the research is not going to be accurate and complete? And what we shall do today is just build on from that. And how are we going to report this? So once we've done our reviews, the next step is how do we report for this review? So I hope you can all remember what we did last week. So what I'll do is a very, very quick refresher to remind us where we are, to bring us up on the same page. So as a quick refresher, if you remember, when we are going to review, maybe someone can remind me very quickly, what are we going to look at? So somebody quickly just give me a quick reminder, give us all a quick reminder. Anyone is welcome to speak. And please don't be shy, we're all friends now. So anyone would like to think, what do we actually look at when we are doing this oversight review?
Good afternoon,
so
Mr. Naeem.
Hi, is that Josephine?
Yes.
Oh, please go ahead.
During the oversight monitoring, usually we are checking the staffing and the infrastructures.
Fantastic.
the informed consents, the patient's medical records, the data reporting, the review of IPs, review of essential documents, review of records and reports, and review of investigational or investigator obligations.
Fantastic. Excellent. Thank you very much. You put that very nicely. So this is overall, as a top line, these are things we'll be reviewing. And when we are doing our reviews, we have to go in very well prepared. So prepared with what the research was, what the protocol is. Make sure you have with you the ICH GCP guidelines as well. And make sure you also understand what the requirements for the investigator obligations are for reporting to ethics committees as well. So all of these things, and thank you very much, Josephine, you've put this very, very nicely. We will go and we will be actually reviewing all of this information. So now let's say, we do our review, and we may see some non-compliance. We will see situations where the protocols are not being followed, and we will see situations where maybe GCP has not been followed. And this is not really unexpected because we know these kind of things do happen in research. However, as an IRB, as IRB coordinators, we have to ensure that if there are these issues, if there are this non-compliance happening, how is this being captured, recorded, and very importantly, how is this being addressed by the investigators? We have to make sure that if the research is being done, it is being done to a high ethical standard. And if it's not, then we have to put some corrective actions and preventative actions in place. Is everybody okay with that?
Yes.
Good. So let's say we do our review. Thank you. Let's say we go see some non-compliance. We call them findings. We see some findings. The next question is, how important or significant is this finding? And then how will I report this finding, or what will I do with this finding? And this is what I'm going to now talk about in this session, is how do we actually look at these findings, and we are going to give them a classification system. So what we'll do is when we go and we do our review, we'll see some findings. And what we'll do is we will classify these findings, and we will use this classification, which I'm going to show you here now. Okay. So what we will do is we will classify our findings, into 4 different categories. We can say that some of our findings are critical. Some of the findings we'll classify as major. Some of the findings we'll say these are minor findings. And then we may have some comments as an IRB coordinator. So critical findings, major findings, and minor findings. Every finding we will give a classification that'll fall in one of these remits. And what I'll do now is go into a little bit more detail of what we mean by critical, major, minor, and comments. So what is a critical finding? And this is the standard definition we're going to use for critical finding. So a critical finding would be when we see conditions, practices, or rights, safety, well-being of subjects, or the quality and integrity of data. So those that adversely affect the right, safety, well-being, and the quality of data. In other words, those that affect GCP directly. Okay. So these are critical. So critical observations, and we'll do an exercise in a little while where we will look at some observations and we'll try to classify them. Critical observations are considered totally unacceptable. We should not be having any critical observations in our research. Sadly, around the world, we do see some critical findings that happen for a number of reasons. So these critical observations are totally unacceptable, and they have a big consequence. Okay? For example, when a sponsor company is doing some research, a clinical study, for example, and they want to submit that data to the regulatory authorities for approval, for example, if there have been a lot of critical findings, the regulatory authorities can actually reject the data. They can say this data is unacceptable because GCP was not being followed. And if that happens, sometimes the sponsor has to go and redo the whole study again to make sure it was followed according to GCP. So that can happen. And sometimes you can also get legal action being done by the regulatory authorities on investigators or sponsors who are doing critical findings, who are doing critical unacceptable findings. So these are critical and unacceptable. We do not want them. Now, I've put a little remark over here, which says that observations classified as critical may include a pattern of deviations that are classified as major, bad quality of data, and or absence of source documents. What this means is, if, for example, we see a finding that isn't critical, but we call it major, but then in that research, we see a lot of major findings, what we can do is say, well, all of these major findings, we are going to classify as critical. Okay? Now, and we'll say more about this as we move on. Now, fraud also is a critical finding. Does fraud occur in clinical research? Anybody know? Yes, no? Does anybody have any idea? Does fraud occur in research? Do you think it does? Everybody's very quiet today. I know it's lunchtime over there in Saudi Arabia. Yeah. Well, yes, we do get fraud in research, but the incidence is very, 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 very low. It's a very low incidence. But if fraud is detected, then it's considered a critical finding. So what I want you to remember here is critical conditions, practices, or processes that adversely affect the rights, safety, well-being of subjects and or quality and integrity of data. So that is what we call a critical finding. Then we have something, if we have a finding which isn't as bad as critical, but is still bad enough, we're going to call it major. And here is a major definition of major. Okay? These are conditions, practices, or processes that might adversely affect the rights, safety, well-being of subjects and or the quality, integrity of data. Critical was practices that adversely, we know they are adversely affecting the right, safety, well-being of data, of subjects, sorry. Major, well, they might, okay? So that's the important thing here. Having said that, major observations are still serious deficiencies and are direct violations of GCP. And I'll give you some examples in a short while. Okay? Again, major, it's not nice to have any major findings in research. We do see some major observations happening. What are the consequences of major findings? Well, major findings are also non-compliance to GCP, and again, reg findings. Now, this is something you need to think about. For example, if as IRBs, you are reviewing some research done by an investigator and you see they've produced the results and you see that there have been many major or critical findings, you can actually say, you know, we don't agree. We don't think that this data is reliable or accurate because there was so much non-compliance to GCP. So that's what we need to think about. I have placed a little remark over here, which says observations classified as major may include a pattern of deviations and or numerous minor observations. We have critical findings, we have major findings. If there are many major findings, we can use our judgment and call that entire thing critical. Similarly, if we see a lot of minor findings, and I'll explain what minor findings are in a minute, if we see too many minor findings in research, we can actually say, well, our finding is it's a major finding. Because there were so many minors, we're going to call it a major finding. Is everybody okay so far?
Yeah, that's fine.
Fine, okay. So minor findings. Well, minor findings are conditions, practices, or processes that would not be expected to adversely affect the rights, safety, well-being of subjects or the quality or integrity of data. So they would not be expected. So these would be minor kind of deviations, and I'll give you examples in a minute, okay? So what we need to do with these minor minor findings is, what they tell us, they indicate us that there are practices which need to be improved at the site. We are nearly there, but there's still some minor tweaks that can happen. Minor findings or minor observations can indicate that this is bad quality data because it's still not 100% GCP, but we've seen some minor deviations over here. And as I mentioned, if you have a lot of minor findings in research, we can call them, lump them together, group them together as major findings. So you have critical, directly adversely affects, major might affect, and minor would not be expected to adversely affect. Oops. Then we have something which are called comments. And these just could be observations you have when you're doing the review, where you think, you know what, if you did something this way, it may actually be better. It could reduce a potential for a deviation. So this is good practice. So this is when you're doing your research, you're doing your review, you can see some issues, findings, you try to understand the processes at the site, how do they do research, and you can come up with recommendations, and these we can call comments. So here are some comments we have for you. Okay. So what I'll do is I'll show you some examples of some findings, and I want you to tell me, would you classify this as a critical, major, or a minor? Okay. So let's look at the first scenario. Here it says, let's pretend you've done a review, and here is some of the things you found. These are your findings. Discrepancies were noted between the data recorded in the case report form and that present in the source data for subjects 1, 2, 3, and subject 4, 5, 6. So what this means is, remember, when research is being done, the medical records are being completed. And then once the medical records are being completed, that data has to be transcribed into a case report form. And both of these should actually be the same. So for example, if in the medical records, it says the patient's blood pressure is 120/70, then that data should be the same in the discrepancies. So let's say, for example, it says subject 1, 2, 3. A start time of IP was recorded, so investigational product was recorded in the CRF as 10:30, while in the source data, it was mentioned as 10 o'clock. Now, what do you think about that? So in the case source data, it says IP was given at 10 o'clock, but in the case report form, IP was given at 10:30. Critical, major, minor, what do you think? So anybody can tell me.
Major.
Sorry?
It's a
Sorry?
major.
علي صوتك يا حنان، علي صوتك.
Major. It's a major.
You think it's major? Okay, how about anybody else?
I think it's a minor.
Sorry?
A minor.
I think it's a minor findings because it doesn't impose risk to the patient.
Oops. So your phone, your voice is breaking there. So I think Josephine, you said it's minor, and I couldn't see who said it's major. Now, let's see you go there when you do this review and you see this, okay? Now, what would be the question you would need to ask?
Will the time make a difference? Will the 30-minute make a difference in the will the 30-minute make a difference in the findings?
Okay. First question you need to ask is, what is the correct data? Yes. Was it 10 o'clock or was it 10:30? Because this could be just a transcriptional error. Yes. And if it says it was 10, it actually was 10 o'clock, because that's what in the medical records. Because remember, the source document is the correct data. Yes, that is the first place the information is documented. That is correct. So if I was to look at it, I would say, well, 10 o'clock is in the medical records, so the subject was dosed at 10 o'clock. That is the correct data. But in the CRF, you've transcribed it as 10:30. So it's an error, maybe a transcriptional error. So if that's the case, I think this is a minor finding, to tell you the truth, because I know in the medical records, it's saying it's 10 o'clock. Do you agree with that? So I would agree.
Yeah.
With Josephine, I call this a minor finding. Now let's look at the next one. It says Date of birth was recorded as the 23rd of August, 1957, 23rd of September, 1957. What type of finding is this? What do you think? Is everybody still there?
It's a minor.
I think it's minor.
Yes,
Also
it's
minor.
Minor.
so this is a minor finding. This is again looks like poor documentation from whoever's they're making errors, yes? Because we know the source document is saying it's 1957. So remember that this is when you are doing this review, you are checking data. So again, this is a minor. I said this is a minor. Let's look at the next one. Blood pressure is recorded as 120/80 in the CRF, while the source data mentions is at 120/79. Major or minor?
Minor, I guess.
Minor again. Start date of jaundice in the past history was 2000 in January 2010, 16th January, but source data says 16th February. What is this again? What do you think that one?
Minor also. Minor.
No. What about this? The CV of minor, exactly. What about this? The CV of the study coordinator is not available in the study file. What about this?
Major,
Major.
Why would this be major?
of course.
Why would this be major? Why would this be major? Question to ask you. So can you all still see my slides? Oh, sorry.
Yes, we do. Yes, we do.
This, again, minor finding. Well, you haven't put it.
By the way, Mr. Naeem, we have a problem with your voice. Do you have a phone beside the computer or something?
I have my phone, but phone
If you can put
off.
it away or something, because I think it's interfering in a way. Maybe.
Okay, I'll put it away.
Okay.
Is that because I can't hear you all properly either. I'm having problems.
Oh,
hearing you all because the sound is okay. So the CV of the study coordinator not available in the study file is a minor finding. It's a minor finding because all it is, well, can you go and place it in the file? Yeah, because the file is the investigator file. So all of these are examples of minor findings. Now, what if when you are at the site and you see a lot of these minor findings, what are you going to think?
Becomes the major.
Be major.
So you may say, because there's so many findings, this looks like poor management at the site, poor quality of data at the site. I'm going to call this as a major because all of these could have a major impact on the safety, right, well-being of clinical trial subjects. Okay. Now, this is a little bit subjective because every kind of reviewer will have their own view or opinion on this. So there is no right or wrong answer, but sometimes it's very transparent. This is a minor finding. Now, what about this one? Site has received 30 vials of investigational product. However, based on the records, only 28 vials of investigational product could be accounted for. What do you think?
Major.
Major, okay. Dr. Hamida says major. Anybody else?
I think major as well.
Why, Dr. Fatima, do you think it's major?
It's just like it didn't say the truth. Like, I mean, it is more big deal than just date of birth or something like that.
Okay, because we've got 2 vials of investigational product missing. Yes.
Yes, and it is like big deals.
It is a big deal because it's good. It's a big deal because according to GCP, all IP should be accounted for. It's like in GCP, you need to look at section 4, investigate responsibilities. So I would agree with you here. I'd say this is a major finding. So I'd classify this as major. What about next one? consent form for one subject, subject XYZ, was obtained after the blood sample was withdrawn from the study specific for a study specific assessment. What about this? Sorry,
Critical. I think it is critical because informed consent should be obtained before any procedure, before any study activities.
Okay, good point. Anybody else? See,
Major, I
else like-
think so.
You think major?
Yes,
would
I
call-
did.
I would agree with Dr. Fatima. Yeah, I would call it major because major, it might adversely affect. We know consent was taken, yes, but it was, and you're right, Ilpa, you're right. No study-related procedure should be conducted prior to informed consent being taken. You must have informed consent first, then you have to conduct any study-specific procedure. So I personally, on this case, I would call this as a major finding because at least consent is there, but it was just done after one specific sample. However, if we, for example, see this happening in 2, 3, or 4 patients where consent is being done after study procedures, I would then call it critical because it's happening over and over again. Does that kind of make sense? Yeah?
Yes.
Yes.
So again, it's a little bit subjective as to what your views can be on this. So Ilpa, you were not really incorrect, but that was your view on how you want to interpret this. But the
Because I
issue,
consider on the ethical issues. Supposedly, I'm considering on the ethical issues.
exactly,
There is some,
exactly.
yeah.
Yeah, and you're right. And even major findings are not good. Major is also saying this is not good practice happening over here. Yeah. So you are right. Yeah. Okay. Now, what usually happens, and just to give a little bit of background information, is sometimes when auditors go and do an audit or inspectors do an inspection at a site, for example, or at a sponsor, they do a classification system and similar to this, and they provide it to the sponsor to respond. And sometimes the responses challenge every finding. They say, we don't think it's critical. We think it's major, or we don't think it's major. We think it's minor. And there's a discussion which can happen. So sometimes you can get challenged as to why are you doing this? Why are you classifying it as this? So it is actually quite a little bit tricky. Now let's move to the next one. Okay. 3 out of 5 subjects reviewed did not meet inclusion criteria 2.3 of the study. The inclusion criteria required that the subject should have had the disease diagnosed at least 1 year before randomization. Subjects A, B, and C were diagnosed only 4 months before the randomization. What do you think here?
Critical.
I think it's
Dr.
critical
Critical, and why do you think it's critical?
because it affects directly the data, the results.
Okay,
It
yes,
doesn't fit the inclusion criteria.
exactly. Good. Anything else? Okay, well, I would agree with you that I would call this a critical finding. Why I would call it critical is the purpose of the inclusion-exclusion criteria is twofold. Yeah, we say why we have an inclusion-exclusion criteria is to ensure that we as researchers, we believe that those people who meet this criteria, it is safe for them to be in the clinical study, and there's a potential benefit which may be given. Now, as an IRB, when they approve the protocol, they approve the inclusion-exclusion criteria, which says that only those people who meet this criteria can enter the study. In this case, there's somebody who doesn't meet this criteria who's in the study, which means that the ethics committee did not give approval for this group of patients. Does that kind of make sense? And in that case, this is a critical finding. I would say critical. What about the next one? Issues were noted with multiple ECGs across different subjects as below. The ECG record for subject E, which was taken on the 23rd of August, 2012, and G, which was taken on the 25th September, 2012, were exactly the same, including the artifacts that were seen. So what does this tell you? Or what do you think this is? So two subjects with exactly the same ECGs and the same artifacts.
I think critical.
Fraud, maybe.
Exactly. So this
Frauded.
looks like fraud to me. This to me looks like fraud. And any kind of
So it's a critical.
it's a critical finding. So this would be a critical finding. So any kind of fraud is a critical finding. So this is something, you know, you have to be aware of as well. So these are just like a few examples I've given you. And what you'll have is when you are reviewing all of these, bear in mind what these definitions are, which I've provided you over here. And all of these are in your SOP, these definitions. And one thing I'd say, you know, don't go really go overboard and call everything critical or major. You have to use a lot of judgment, use a lot of balance, look at the entire picture of what is happening at the site. Some findings are going to be blatantly obvious. This is critical, this is major. Some may not be that clear cut, and you may need more information from the investigators before you give them a classification on this. Is everybody okay so far?
Yes.
Okay, so as it's hot here, it's time for a Coca-Cola, I would say. Okay. So why I put Coca-Cola here, I shall tell you. Now, what you do is when you are observing these findings, you need to document these findings, because these findings you are going to give to the investigator and you want a response. You want a response in the form of a CAPA, which is corrective and preventative action, which I come back to in a little while, but I did talk about this last week. So when you are going to document your findings, you'll be making notes, or this is a finding. When you document the finding, be very, very clear. I want you to be clear, so that's the C. Be objective, state what you have seen. Be concise, make it very short, and make it accurate. Just like the examples I gave you, clear, CRF says this date, medical records say this date. It's clear, it's concise, it's accurate, it's to the point. So be very brief, very short. This is how you will document every finding. Okay? So that's just something to bear in mind when you're documenting these findings. Make them very clear, make them easy to understand, very objective, and then your view will be critical, major, or minor. But this is what I have seen. Okay. Everybody okay with that? Excellent, great. Oops. Now, the corrective action, preventative action is what I'm going to just touch on now a little bit. So what happens, and I'll clarify this, okay? Whenever you see a finding, we want this finding as IRB coordinators who are providing this oversight to be addressed. We want the investigator to tell us how they're going to resolve this. So what we want is something very simple. We want a corrective action and we want a preventative action. And this is what a CAPA is, corrective and preventative action. So the corrective action is the action that's going to take when the issue has happened. So you're going to say, I have seen now the CRF says one date, the medical records are saying a different date. What are you going to do? That is a corrective action. So as a corrective action, for example, I would say, you know, the date in the CRF was incorrect. I will change the date. So I'm going to cross the date out, put the correct date in, initiate date in. Preventative action is what are you going to do to make sure this doesn't happen again? Well, I may say, well, I'm going to train my staff on good documentation practices, or I may put a second QC process in place. Does that make sense, everyone? Yes?
Yes.
No? Yeah. So this is a corrective preventive action. Okay? Corrective preventive action. So I want you to remember this because CAPA is a buzzword. CAPA is mentioned in GCP as well. Corrective action, preventive action is mentioned in GCP. So now what I want to do is I'm just going to go back to one of my findings, and I want you to tell me, based on your experience, what you think the CAPA should be for one or two of these findings. So if I go back here, okay? Now, here let's say I am the reviewer and you are the investigators, and I tell you, I have seen this. What do you think would be the corrective action here? There can be many corrective actions, but I just want to ask someone to give us a corrective action. Shoo. So basically, I've got 3 out of 5 subjects who do not meet the inclusion criteria who are in the clinical trial. So what could one of the corrective actions be?
Replace the participant.
Sorry? Replace the okay. Do you mean withdraw the participants?
Yes.
Yes, okay.
Yes.
That's fine. Exactly. That could be one of the corrective actions as well. Clearly, these people shouldn't be in the clinical trial. Maybe we need to remove them from the clinical trial purely because of the safety reason. So exactly. So that could be a corrective action. What about a preventative action?
Be more accurate when picking the subject.
Exactly. Maybe have a checklist that will help you with the inclusion exclusion criteria. Maybe have a second review by another physician before you actually put the patients in. So that's a great example. Now, this is what you would want to see when you are giving the investigators the CAPA and you want their responses. You want to see corrective action and preventative action. So let's just look at one more over here. The consent form for one subject was obtained after blood sample was withdrawn. What's the corrective action? Oh boy, this is a tricky one. What could the corrective action be here?
Maybe make a report to the company or sponsor.
Very good. A good point. Okay, but there's not a lot we can do really because it's happened. Yes.
Mm-hmm.
Well, they are in the study, but they just signed the consent form after one procedure was taken. So maybe what we can do is document this. Maybe also inform the subject. Look, I shouldn't have taken this blood sample before you signed the consent form, but you have signed it. It's okay. Do you still wish to continue? Yes. Think of the subject's rights over here. So that could be a corrective action. Okay, we need to document this somehow. Preventative action. Anyone like to give me an idea? Phew. Remember, these will be coming from the investigators, and you'll be happy. You would be reviewing these and saying, okay, yes, I agree with this or not. But the preventative action could. Go ahead.
Preventive action could be like reading the required steps that should be taken in account before doing the experience.
Exactly, yes. Maybe, retrain the site on informed consent procedures, or you could be, do you have a SOP in place for informed consent procedures? How do you do it at the site? Why did this mistake happen? So, yep, lots of things there. So this is great. Wonderful. Thank you. So this, I want you to now remember, is when you have findings, you will be doing these CAPAs, okay? Which look back. So how you will document a CAPA, there's a CAPA plan available, and there's a template of this available for you. And this is how you'll do it, okay? So what you will have is a table which looks a little bit like this. Here, you'll put your finding, okay? So very in the COCA format, complete, objective, concise, accurate. You'll put that finding over here. Then you will give it your classification. I think it's critical, major, or minor. Okay? So these 2 columns are going to be filled by the IRB coordinator who did the review. Okay? You will discuss this at the closing meeting if you have time with the investigator. And you say, the remaining columns, I want you to complete. And once these are completed, you're going to send this to me so I know exactly what's happened. So what the investigator has to do is put the corrective action, just like we discussed a corrective action, and they'll put the preventive action. They're going to decide the target date. Look, they have to plan, they have to plan this. So this is going to be our target date. By this date, we will have this done. And then when did they actually do it? Okay. And who was responsible for following up on this CAPA corrective action and preventative action? So this is the kind of plan you would be doing. Is everybody okay with this so far?
Yes, we are, yeah.
Okay, perfect. Excellent. Great.
Yeah, okay.
So, excellent, great, okay. So the process, the procedure is this. you've gone, if you just a recap, you do an opening meeting, you discuss what you're going to do there, you do the conduct, and then you at the closing meeting you're discussing your findings with them. You're telling you these are all the findings. Now, once you have completed your review, you have to report this review, and there's a reporting procedure we're going to follow. So following the closing meeting, after the closing meeting, you have to write a review report. Okay, so this review report, and there is a template available for this review report, will document all of your findings, your classifications, and what your recommendations and views are. This report must be done within 7 days of completing of the closing meeting. So within 7 days of the closing meeting, you will write this review report. What you will do with this review report, you will send it to the EC chairperson, and they will obviously be informed what's happening. Now, this report comes within 7 days. Now, what if, for example, you were at the site and you saw some very serious critical findings? Yeah, if it was something very critical, then within 24 hours, you must inform the chairperson. So within 24 hours, the chairperson needs to be informed of this critical issue over here if immediate action needs to be taken. Okay, that will be followed up by a full report within 7 days. So the report goes 7 days. Oops. This report then is also sent to the principal investigator. Okay, so investigator knows, okay, these were all of my findings, etc., and they will have to complete this CAPA template. So this CAPA template with all this information will be documented. They have to complete this now. They complete those sections where the CAPA comes in, the actual target completion date, and the responsible individual. They have to complete this, and these responses have to be sent to you within 30 calendar days. So they have 30 days to get back to you with all of these CAPA findings. Everybody okay with that? And what you will do is you will maintain a CAPA tracking log. Because you have got the report, you know what the findings are, keep a CAPA tracking log, and as soon as these CAPAs, you're happy that the CAPAs have been resolved, then you just keep this on a tracking log. And this is the basic kind of process you're going to follow when you are doing this CAPA reporting. Before I move any further, does anybody have any questions or something I said which was not clear and you would like me to say it again or explain further?
We're fine, thank you.
Is everybody okay? Because I want you to take this opportunity, please, to ask me any questions.
Naim, I have a question.
Yes, Josephine.
Yes, if the PI did not resolve this CAPA within 30 days, especially this time of pandemic, so what we will recommend to them? What would be the action, further action for this?
Okay. For example, when we're in a situation where pandemics are happening and things have gone a little bit, haywire, maybe the EC chairperson needs to make a decision as to how we're going to address this. Yeah. What's important over here is, yes, we do acknowledge that there is going to be, where we'll have situations sometimes that are out of our control, and we may need to prioritize our importance of how we're handling situations at a site. So something could be here is maybe as the IRB committee, they have to decide, okay, fine, 30 days has gone over, we'll give them a few more days. That's just clearly up to you. Is that okay, Joseph?
Yeah, it's clear. Thank you.
So there you go. Now, what could happen is, while there's this, the investigator may need help from you, okay? And that, please do work with them. They may advise, say, what do you think the advice should be? Give them some advice. Please do that. Something very important I want you to remember and take away over here is, as an IRB coordinator, as IRBs, we are working with our investigators. We are here to help them. So So they should see you as a guiding light, a shining light, a fountain of knowledge who's telling them how to do things right. They shouldn't be afraid of you. Whenever there's a compliance review, everybody gets afraid, and they shouldn't be, because you're here to see, how are you doing? If not doing well, what you can do to help you, to educate you, to train you, do whatever you need to do. So there you go. So that was actually the process we have. So
Excuse
from
me, Mr. Kim, I have one concern.
Yes.
For example, we were able to conduct a monitoring, and then 1 week after the monitoring, supposedly something will be done. But because of this COVID, now we were not able to prepare a CAPA, but we informed the investigator and he promised to complete all those data within a specific period. Is it okay without the CAPA?
Yes, I think that is fine. Yes. Is it okay, Opa?
It's okay.
I think it's okay. Yeah. As long as we've got a situation here where things can go a little bit. What you'll be seeing here is a little bit of non-compliance to your SOP itself. That's what you're seeing, because the SOP which is on this is not being followed. But we're in a situation where things have gone a little bit out of control for us. Because, for example, we can't go on site, we can't do lots of things, and we have to be a little bit flexible. But just document this, I'd say.
Okay.
Yeah. Okay. Okay, so simple process. Remember, what we did was we selected our sites, which sites, which study, and we based this on a number of factors, recruitment rates, experience of investigators, safety, etc. Once you've selected this, we inform our investigators or our sites, we give them a notification that we're coming. We come, we have an opening meeting, we're very transparent as to what we will do. We go in very, very well prepared. We then conduct the whole review process. It may take 2 days, 3 days, 1 day, really depends on you. And then we have a closing meeting where we discuss these findings. Then we write the report. We have the CAPA plan template. It's followed up by the investigators. And that is the entire type of oversight process. Now, if you remember, when we first started, I said I'm going to work in reverse a little bit. We're going to talk about conducting the review. But what about the role of the IRB coordinator in the preliminary review? Yes. So when for example, a research proposal or a protocol or a clinical trial proposal is submitted to the IRB, what type of review do you do? So even before the study started. So maybe someone can tell me, what would you do? Let's say I'm an investigator and I make a submission to conduct a trial. What will you look at as an IRB coordinator?
In our institution, we have checklist. We have checklists. So we're giving this to we're giving this to the principal investigators. What are those items to be fulfilled before submitting it to the IRB?
Okay, and what are they, if you wouldn't mind sharing them with us, please?
Copy of the protocol, the informed consent, and this,
now,
it should.
Sorry, I'll just stop you there. So when the research proposal comes in, the protocol comes in, what do you do as an IRB coordinator? Do you just say, "Oh, it's here, that's it," or what would you look for?
We are looking on the design and the type of the study. Yeah.
Yes.
The population and how they are going to on the procedure and how they to conduct the research itself. The safety,
so
we're also looking at the safety.
Yeah, Karen, good. This is great. So before it even goes to the IRB meeting to convene, you are checking to make sure all of these things are in place. Is that correct, Ilpa?
Yeah, all these things should be correct.
Okay, excellent. So there you go. So that's something you need to be looking at when the proposal comes in. Look at the design, look at how the data is being collected, look at how the safety is going to be reported. All of these things which Ilpa has mentioned, fantastic. We'll look at that. Excellent. Then the informed consent form. What do you look for in here?
It should be on the, for example, on the layman's term, the safety, the confidentiality, the name. It should be with the name, the date, and the signature. So we have also the checklist on that.
Fantastic. So a checklist, and this is great. So a check. So when you are looking at the informed consent form, you're going to make sure that the informed consent form contains the fundamental elements what ICA GCP is saying should be in the consent form. Is that correct, Ilpa? Yeah, so you have a
Yeah,
checklist.
yeah, we have the checklist based on the ICP.
Fantastic. Exactly. And in GCP, it's section 4.8.10, which tells you what goes in there. So important, great. You look at this to make sure it's fully, you know, it has all the elements, it's written very well, etc. So you do that. Excellent. I like that. What else would you look at, Ilpa? Or anybody else would like to add? And in your preliminary review? Well, you'd want to look at the investigator's brochure, safety information. You know, has that been provided? You're not going to critique this really, because this is something which a sponsor has developed. It's information which the IRB members need to understand the background of the study, to understand the background of the drug, So is that over there? You'll want to look at, is there any other written information that's going to be provided to the subjects? Is that there? If advertisements are going to be used, you want to make sure they're being submitted as well. You may want to look at any payment or compensation to the subjects. Is that information being provided? Because when the IRB is going to convene or sit, they'll want to see this information. So you're like a gateway here. Are they providing all of this information? Is the CV and the GCP certificate of the investigator there, the sub-investigator? You want this. If not, send it to us, please. We need this. If applicable, the insurance certificate, the clinical trial agreement, if you're looking at that, the case report forms, any questionnaires, subject diary cards, etc., or anything the EC is mandating we want as part of a submission, you will be checking that. Now, so Josephine and Ilpa, you mentioned you have checklists. Is this something which is part of your checklist, or have I missed anything out here?
Yeah, that's all.
Yeah, it's part of our checklist, all of these required documents.
Okay, perfect. Okay, so that's something very important. So as a preliminary reviewer, as an IRB coordinator, you're checking the comprehensiveness, is it actually a full package which we as an IRB want, not just a checklist, but then going into a little bit more detail, looking at the protocol, looking at the consent form, and looking at some of the other documents. So once this happens, it goes to the IRB, they'll do the review, give their decision, approve or disapprove, conditional approval or whatever. And once the study starts, then the process kicks in of you identifying the site, notifying the site, etc. So that is actually what I really wanted to say over a webinar series. So I finished about 10 minutes early because I wanted to give some time for any specific questions and answers. So before I do that, I'll just do a quick little recap of the objectives. So I hope you now understand what your role is and responsibilities are in the oversight and monitoring of health research studies. I hope you've gone through some of the activities that are involved and how you can demonstrate, or how the investigator can demonstrate that they followed GCP, they followed regulations, and very importantly, that this right, safety, well-being of subjects was protected. And hopefully with the information we've given, the few tips we've given, you can more effectively provide oversight, be able to conduct, in fact, an oversight of health research and clinical studies. So on that note, I'm going to open up to any questions anybody may have. And what I'll do is I'll stop sharing my if I can, my slides. Oh my goodness. So anybody have any questions?
Yes. A postgrad degree to do or to conduct research?
Okay, no. So what's basically, according to GCP, you have to be adequately qualified and trained to conduct research. Now, what happens, we have to follow what our local regulations are saying as to what is required for an individual to be, for example, an investigator. For example, in some countries, it's mandatory for investigators to be physicians, for example. But in other countries, there's no requirement as such. It's purely based on your experience and training that is required. So there is a lot of flexibility there. Does that answer the question?
Yes, sir. Another question, please. Is there any kind of hands-on training that you can go to a university and work with the investigators on research to get more training hands-on? For me, I'm more of a practical learner. I need to work on something to be able to understand how to do it correctly, more than to go lectures and reading books. Can that,
Yes,
is that possible to do?
I think that's a very good question to ask, because there isn't any kind of specific training that's available to do something like that. What you can do is, and if it's an option, for example, you may want to think about this, is actually, go to an investigator site and observe them. You may ask to do that, or if you want, tell them, can you be part of this study team, for example, a study coordinator even, to give you that hands-on experience. So it's a very good point there. There isn't actually any kind of formal kind of hands-on type of training available. What we do is we do simulation-based type of training, which gives you an idea of how to do things. But that is something, which you may wish to consider is, maybe the institution wants to look at establishing some kind of, buddy system where people are given the opportunity to spend a bit of time at the site. So it's a very, very good point you've raised there, Dr. Hannah.
Thank you, Mr. Naim.
Thanks a lot for this enjoyable series of interactive webinar. I have a question, Mr. Naim. Can we consider changing the sample size for any study as a critical findings?
Okay. Yes, what can happen is, if you have certain, when you're talking about critical findings, we are actually looking here more at compliance to GCP, compliance to the protocol. We won't really be looking at changing the sample sizes. Usually the sample sizes need to be changed for other types of reasons. For example, there could be endpoints, there could be, for example, new treatments coming in, patient profiles, different arms want to be added, for example, you can do that. What you can do, for example, is during the initial review of the preliminary review of the research, if you feel that, this is not the right sample size based on your experiences, based on your knowledge, then you can ask the investigator to justify why he has got this sample size, for example. But when you're doing the review, when you're doing the oversight review, your objective is actually here to look at how the safety, right, well-being of subjects is being protected, rather than going into the more of the statistical design side, because that should have been addressed before the study was running. I don't know, does that, Dr. Nora, answer the question?
Yeah, sure, as usual. Thank you very much. I appreciate it.
It's a pleasure. It's a pleasure.
Mr. Naim, I have a question on the multi-center studies.
Yes.
Correct me if I'm wrong. If this is multi-center, can we disapprove a study? Or I don't know, because sometimes we're not able to meet on the standard on the particular institution.
Yeah. So what happens is, you have to see, your IRB, which sites does this have jurisdiction over? If, for example, there's one IRB and you're responsible for 10 different sites, for example, yes, you can at any time point withdraw your approval from one investigator only. You can do that. If they were under your jurisdiction, you have the power to do that. You definitely do.
At least I know now.
Yeah, because you can. This is your role is to protect the right, safety, well-being of subjects. If at any time point you think that this is being compromised, you have to act in the best interest of the subjects, and you may say that this is not being conducted properly. The subject's safety is at risk. I withdraw my approval. You cannot do the trial.
Okay, thank you.
I wish, Mr. Naim, if you can elaborate to them the difference between fraud, falsification, and fabrication. If you can elaborate a little bit so that they know the difference. Thank you.
So fraud by definition is intentional, doing something intentionally which is wrong. And part of fraud, there are many things. There could be withholding data, or there could be fabrication of data, which is making data up. Yeah? So within fraud, you can have these two different kind of things. I may either be withholding information, so I'm not showing, for example, I really want my study to continue, so I'm not going to report the serious adverse events, for example. That could be a thing. That's withholding. Fabrication is making up data. So for example, the patients missed their visits. You know what, I'm going to just make up the data, so at least there is some data available there. So that comes under the fraud. Dr. Tariq, does that kind of answer the question?
Yeah, that's great. Falsification.
Sorry?
It's okay. Thank you.
A pleasure. No pleasure. Very good. The incidence of fraud is very, very low. It's less than 1% in research, of detected fraud. It's very, very less. And usually a lot of when fraud is detected or misconduct is detected, it's actually unintentional. They didn't mean to do it. And majority of it is that, believe it or not, it's purely because investigators don't know, clinical practice, medical practice is very different from clinical research, because you have to follow laws, regulations, documentation, etc. And you have to, as one thing I'd say as IRB coordinators is really educate your sites, your investigators on GCP, on how to conduct clinical trials, on good practices, for example. That's some advice I could provide. Yeah. Good. If there are no other questions, I'd really like to thank you all very, very much. It's been
anybody have any question from the coordinators? Anyone have any comment?
Just a big thank you, Mr. Naeem. We really enjoyed this series. Thank you so much.
Thank you very much, Dr. It's a pleasure. I really thank you all for attending this. And I know web conference is very difficult. It's been a real pleasure getting the chance to speak with you all. And I do hope next time when I can fly to Saudi Arabia and come to see Dr. Tariq, I can meet you all as well. It's wonderful to see you all.
Yeah, for sure. It will be our pleasure as well. So thank you, Mr. Naeem, and all who participated in the workshop today, as well as for all the audience. And we hope to see you again in future research-related webinars. Thank you very much for your time and attention. Thank you.
Thank you very much. Thanks. Bye-bye.
Okay, bye.